Hello, everyone. My name is Valerie Cordero, and I am Co-Executive Director of Families for Depression Awareness. We provide education, resources, and actionable advice to family caregivers so they can support their loved ones living with depression or bipolar disorder. We have been exploring treatment options for people living with different mental health conditions. Today, we are speaking with expert Dr. Maria Sullivan. Dr. Sullivan is a board-certified psychiatrist and clinical researcher who specializes in the treatment of addiction. She also serves as VP of Clinical Development for Pear Therapeutics. Dr. Sullivan received her bachelor's degree from Harvard University, her Doctor of Medicine from the George Washington University School of Medicine and Health Sciences, and PhD in psychology from the University of Chicago. Welcome, Dr. Sullivan.
Thank you so much, Valerie. It's a pleasure to be with you and your audience.
Thank you. So we'll just start by you telling us a little bit more about your professional work as an addiction psychiatry researcher and anything you want to say about your clinical practice or the work that you do.
Thank you. I'm happy to touch on all of those topics. First of all, I think it's a really timely discussion because as you know well, the rates of addiction have really skyrocketed during the pandemic, and this problem has been thrown into very high relief. I first became interested in addiction psychiatry because during my training at Columbia in psychiatry, I was confronted with a lot of patients who were really suffering through the chronic relapsing course of either alcohol dependence or substance use disorder. And I would see them in the clinics and the emergency department. And I was really struck by how much suffering and perseverance is involved in the experience of these disorders. And I also was really impressed by the dramatic transformation that occurs when a clinician can intervene and successfully treat this condition. Just the gratitude and the return to health that the patient experiences is so rewarding. And I have, from those years, I've always maintained a private practice in New York. It's been a part-time practice, which complements my full-time research career. And after many years on the faculty at Columbia, I moved into research within industry, and I'm working on novel treatments for addiction there as well. I would say that about 3/4 of the patients I see, though, in my practice do have either an alcohol or substance use disorder. So I just want to stress that these are very prevalent conditions. And of course, they often co-occur with another psychiatric condition or mental health concern.
Well, I'm glad you said that word co-occur because some members of our audience may have heard the phrase co-occurring disorder before. Can you please explain what is a co-occurring disorder and how do you know if somebody is dealing with a co-occurring disorder?
Yes, I'd be glad to. So co-occurring disorders are two independent conditions that can occur and often do occur in the same person at the same time. And we understand that there are environmental stresses, genetic vulnerabilities. There are good reasons why a person may be subject to experiencing one or more of these conditions. What's important, I think, to note are two things. First of all, just the high rates at which, for instance, mood disorders or anxiety disorders co-occur with addictive disorders. Just as an example, about 1/3 of patients with a major depressive disorder also have a substance use disorder. And even patients with an anxiety disorder, about 25 to 30% of them have a second substance use disorder. What's, I think, important for people to realize is that although they are independent disorders, they can affect one another's course. That is to say, not diagnosing or treating one of these conditions will often aggravate or worsen the course of the other. And both substance dependence and also major depression independently are risk factors for suicidal thoughts and also for the greater use of mental health services. So they really need to be taken seriously and addressed both independently and as they occur together. You asked about how to diagnose separate conditions, and I would say that the way that a clinician can make a diagnosis to determine that a patient has both, let's say, a mood disorder and a substance disorder, is by taking a careful history that will reveal that there was a time in the patient's life when he or she was suffering from a mood disorder without the substance use being present, or similarly, that after a person has achieved abstinence, they are still experiencing symptoms of depression or another mood condition, which again do deserve to be treated separately then.
How have you seen that affect families? When somebody in that family has a co-occurring disorder, what can that look like in a family?
It's an excellent question, thank you. I mean, I want to say that for individuals who are struggling with alcohol or substance use disorder, their addiction, it's not just a personal issue, it definitely and directly impacts a family. I mean, spouses, parents, children are all affected, and they're affected by issues like interpersonal conflicts or secrecy or the lack of trust that an addiction will cause within a family. And witnessing a parent suffering from addiction, which can include rage or violence or sometimes neglect, is traumatic for a child. And this can have long-term effects that can lead to mood and anxiety issues. Certainly children often blame themselves and experience inappropriate feelings of guilt or unworthiness or later dysfunctional attachments in adulthood. And the spouse of somebody who is addicted to alcohol or another substance often finds that their trust in the relationship is eroded. The addicted partner will become more guarded, secretive, emotionally unavailable. And unfortunately, sometimes as the addiction progresses, they can also become either emotionally or physically abusive. And in addition to all this, the addicted person may be depressed or emotionally labile, and this can create just in general a sense of tension or an unstable environment in the home. And sometimes a spouse will get drawn into trying to cover for the person's addiction. They'll take on a caretaker role, they'll try to avoid conflict, they'll define themselves in relation to the other and really fail to meet his or her own needs. And we call this pattern of behavior codependency. So in general, it's really important to recognize that addiction directly impacts not just the individual, but importantly, the all close interpersonal relationships and especially dynamics within the family.
We get this question from families a lot. Do you treat the substance use issue first, or the depression or bipolar disorder or underlying mental health condition first? Which one goes first, and how do you know? And what generally are the treatment protocols for people who are dealing with co-occurring disorders?
Sure. Perhaps I'll take the second part of the question first. In terms of deciding which condition to address first, sometimes there is one condition that is posing the most acute danger. So for instance, someone who is heavily enmeshed in opioid use disorder and is really in grave danger because of the risk of overdose or death, that really requires immediate treatment. Similarly, I would say a patient who is profoundly depressed to the point that they are really not able to seek treatment for their addiction, that depression really needs to take prominence and priority and be treated first. But in general, it is important to treat both types of conditions. And fortunately, the good news is that there really are effective treatments available for addiction. Behavioral therapy, and in some cases, pharmacotherapy. The kinds of behavioral therapies that have the strongest evidence base behind them are cognitive behavioral therapy, which is a type of therapy that helps people identify dysfunctional thoughts and beliefs, such as those that can drive relapse behaviors. Another is contingency management, which really provides positive reinforcement through things such as spinning of the wheel, monetary enforcement, words of encouragement, just non-drug reinforcers that seek to reinforce a person's engaging in healthy behaviors that are supporting either treatment engagement or abstinence. And as regards the medical management of addictive disorders, some patients, when they present for care, are physiologically dependent on a substance, be it alcohol or opioids, and they will require inpatient detox to safely manage withdrawal symptoms. But after that intensive inpatient treatment, after detox, the clinical focus then really shifts to preventing relapse and to shoring up the person's commitment to abstinence, to helping them really frame an environment and discover internal resources that help them commit to the long term of recovery. And this work can be carried out either individually or in group therapy, as well as with the help of 12-step programs or self-help such as AA. Now, someone who has a dual diagnosis, which let's say is an addiction plus depression or bipolar disorder, they really do deserve treatment for both conditions. As I mentioned, one will influence the course of the other. And, if you think of it, someone who's suffering from a depressed mood may end up self-medicating with alcohol or drug in an attempt to improve their mood, or in the case of a manic episode, in an attempt to control the energy or impulsivity or racing thoughts. And of course, then this alcohol or substance use will very often lead to non-adherence with medication or treatment that's meant to support mood. So you really get into a kind of a vicious spiral with both relapse to the substance use disorder and potentially an acute mood episode. So again, it's so important to look at both and be prepared to treat both conditions.
So if a loved one is living with a mood disorder and substance use problem, what can caregivers do to support them? What is the role of the caregiver? You mentioned before that you don't want the caregiver to slip into a codependent kind of relationship with them. So what are the right things that family caregivers can do to support a loved one who's dealing with that?
Thank you. That's probably the most important question for many in the audience. And I would say that it's important for family members to recognize that a person who's suffering from depression or a substance use problem is not only in distress, emotional distress, which may manifest as anger or sadness or just emotional withdrawal, but they may be in denial about the very nature of their condition, because it's true for both depression and addiction that one's frame of reference tends to get very narrow, and it can be hard to remember really, what your best self was like, what your own authentic personality was, and how it has changed or been compromised. And also, it's hard to think about or plan for the future. So family members can really best support a person with a mood or a substance issue by letting them know that you genuinely care for them, you're ready to support them, you recognize that they are suffering from a disease, and most important of all, that there is effective help available. And I would say many times in my own practice, a patient has come into the office for an initial evaluation, and they may say something like, I don't think there's anything you can do for me, but my wife or my husband asked me to come in because he or she says I'm always irritable now, or I've stopped wanting to see friends or some other enjoyable activity. And what I, as a practitioner, would tell someone who's starting treatment and may have some misgivings is that they don't need to have complete faith in either me or in the treatment, but they just need to be willing to suspend despair and to give the treatment a try, because there really is effective treatment available. And I also let them know that when a medication such as an antidepressant begins to work, they will actually not feel altered or drugged. They'll actually feel like they're returning to their authentic self. And again, it's as a clinician, it's very rewarding to see that. The patient is really experiencing the clearing away of symptoms that were obscuring their own personality. And often it's the family member who is the first one to notice this. I can recall one patient saying to me, I'm not willing to say the medication's working yet, but my wife says it is because it seems like we're not arguing anymore, so maybe something's happening. So it really is the family that will first notice those benefits. And one other thing I'd like to add is that, if you are a family member of a person who is suffering from addiction and is refusing treatment, there's still something that family members can do to seek help. And I wanted to mention specifically the community reinforcement and family training, or CRAFT approach, which is a kind of training and support groups that can help family members to avoid directly entering into conflict with the patient or trying to force them to change, but really can teach a loved one how to, in a more, if you will, sort of respecting the person's autonomy and their choices, but still providing support for the right choices. So when they engage in actions that are compatible with sobriety, or they show control, to really demonstrate very positive support. So, that might look like if someone comes home intoxicated, you don't pick a fight or call them out on it. You just withdraw, you leave the room. But if they come home sober, you have, a chance to have a really nice conversation and spend quality time together. So it's that kind of positive reinforcement that really can make a difference. And there's a lot of data behind this, that this type of family approach can work for someone who's not quite yet ready to see the problem. So I just wanted to mention that as well.
I think that's really helpful for people to know that even if the person is resistant to getting help, there are things that you can do to support them and to be there for them, and to try to maintain that relationship so that when they are ready to get help, you can be a support, not take over the process, but be there alongside them and provide whatever support that you can and that they will accept. I think that's really important. You have to be there for them. So the last thing I want to ask is, what gives you hope in terms of the treatment of addiction? And what do you think is better maybe today than was 30 years ago, 40 years ago, 50 years ago? What gives you hope?
Thank you. I like the question very much. I would say, first of all, I think that there has been a lot of progress made in moving away from the stigma that used to attend addiction, both stigma from others and even self-stigma. I think there is a much greater recognition that these are neuropsychiatric conditions. They can be treated like other mental health conditions, and people who are suffering from them deserve the full extent of what is available from clinicians. And I also want to say that I'm very encouraged by the amount of research activity that's going on right now to expand the range of pharmacotherapies, of medications that can treat addiction, whether they're oral meds or long-acting injections or even vaccines. And also the adoption of telehealth and other technologies. Again, telehealth very much spurred on by what we all experienced during the pandemic. But there's a very kind of bright horizon of newer technologies, including digital therapeutics, prescription digital therapeutics. And just to give kind of a one-word introduction to what these are applications available on a mobile device that really are based on evidence-based behavioral therapies. So for instance, the FDA has approved an app for the treatment of opioid use disorder for patients who are receiving buprenorphine, but really need that behavioral therapy piece to help them. And what this looks like is cognitive behavioral therapy, again, delivered through an iPhone, and contingency management delivered in the same way, and reinforcing concepts, really just providing an extension of care that a clinician just is simply not able to provide at all hours for patients. And it really is an extension both of the temporal reach that a practitioner can have. So patients can engage in this late at night, early in the morning, and also geographically, that patients who may not be able to come into the office physically can still have a richer experience of treatment by making use of some of these behavioral therapies. We are witnessing a very dramatic expansion of these kinds of technologies, and I think that what's really exciting is they're going to improve access for patients who have not up until now been able to either afford or even just physically access effective treatment. And so I think that we're going to be witnessing really the transformation of psychiatry and addiction medicine as these technologies evolve. So I'm feel privileged and excited to be part of this.
That key word of access is so important to us as well. We want to make sure that anybody anywhere is able to get help and get better if that's what they choose to do with their life, and that they are not restricted because of their geographic location, their racial background, their language background, none of those things. We want access for everyone. If they are trying to address issues of mood disorders, substance use disorders, that's so important. What would your final message to families be who could be watching this and looking for a bit of hope or looking for some encouragement, what would your message to families be?
I would say that it's really important to recognize that there is a breadth and depth of help available that is, it's hard sometimes to believe it's out there, but it genuinely is. And I think that, you know, it's important to start with where the patient is. And as I say, if there's a co-occurring condition, it might be that the patient is more distressed by the depression than he is by the heavy cannabis use. And so, you know, whatever it is that the person in your family recognizes as distressing is kind of that's the invitation to say, you know, you don't have to suffer from insomnia. You don't have to be this anxious. And I'd like to help you find some help. And it is really remarkable that once patients come into treatment and they realize that from the clinician standpoint, their experiences are part of a pattern. It's not that they themselves have failed or fallen into this rut. This is actually the way the disease presents. And it's very eye-opening for a patient, you know, when he says, how did you know that? And I'm able to say, because this is what happens when you've been drinking in that way. You know, it's just very validating that they are experiencing a condition that we have been able to identify, we know how to treat, and you know, baby steps lead to larger steps. And I think that getting that first foot in the door of treatment is so important. And many times the patient just needs to know that, you know, even though maybe in their eyes they've disappointed family members, that there's somebody in the family willing to kind of step in and if need be, accompany them to the first visit, but really help them get